further ado, welcome to all of you. Welcome to our panelists. And Dr. John Keeve, please take the microphone.
Thank you, Jens. For most of you watching this tonight, you have to look east to find Spokane. Spokane's also where the new day dawns and where the future comes from. And hopefully this will have an impact on the future of orthopedics, and hopefully we can continue to collaborate with our Western colleagues. Many of you probably have not been to Spokane, but Spokane is just in the Idaho border. There are about 520,000 people in Spokane County, but we have a very large catchment area, and the largest cities, north, south, east, and west, are listed here. So there are a lot of people that come from a long ways away to come to Spokane, not usually for the food, but mainly for the healthcare, which is the biggest industry in Spokane. As I mentioned before, we're very close to Idaho, which, as far as I know, does not have, or at least they don't think they've had a problem with COVID, although the numbers speak differently. I'm a member of Northwest Orthopedic Specialists. I've been in Spokane and had the good fortune to be in the same group since 1988. We've grown from 7 when I joined to now a total of 40 providers. And you can see the sort of breakdown here. We started an ambulatory surgery center in 2004, much to the horror of the local hospitals. We also have our own MRI, which we use quite a bit. In our group, we have virtually all specialties represented. Most of our associates are fellowship trained, some with multiple fellowships. And more recently, most of the people who are interested in working with us have done fellowships. We have 4 new physicians on partnership tracks, and you can see their names. They've been a great addition to the community, and we're happy to have them with us. I think the biggest change in our group in the last few years is we have a robust and dedicated leadership team. They have the unconventional practice of using data to help us make decisions, which is heretofore was sort of, you had a hunch and maybe we should try this, but now we actually have metrics and performance data that we use to make decisions about various things in which direction we should move. That's been a huge change in how our practice has been run. Not everybody's wild about it, but we have good reasons to do that. And I think that overall profitability and efficiency of our practice has been enhanced dramatically by actually using numbers instead of, gee, I think this might work. We also are members of the Ortho Forum, and we use their data benchmarks to help guide what we do. And we have very granular data that we collect ourselves and analyze ourselves and use that to make decisions about what we do in terms of need for new associates and what markets we might get involved with. We see about 75,000 patients a year. We do about 5,500 surgical cases in our ambulatory surgery center and about 6,000 interventional pain cases. Our inpatient cases are roughly 3,700 or so between the 4 hospitals in Spokane, and we do about 3,500 MRI scans a year. These are annualized over the last 3 years, and they've all trended upwards, especially ASC cases in the last couple of years or so. Just for example, this is, and I'm sure Neil would discuss this in greater detail. This is our trend in total joint replacement at our surgery center. You can see the numbers, and I don't have the most recent data for the last few months, but we're running out of room to do joints at our surgery center, in part because patients are escaping from the hospitals gleefully in most cases. And we've just kind of run out of room. So how we expand this is sort of difficult, and whether we start doing them on weekends or expanding the hours or how we do it, we're not clear. We do not at this point keep people overnight, although that's probably our next move, is to keep people for 23 hours in the same facility. But the ASC has been a wonderful tool for the community and certainly for us. We also are expanding some of our service lines. We've opened 3 urgent care centers. Some are working better than others, and it's a little hard to assess whether it's COVID impact or just timing or location. But we're continue to collect data and try to give patients an alternative to expensive and inefficient emergency room care. We also have a physical and occupational therapy in 2 locations, and that's been really helpful in terms of integrating how we take care of our patients. We're averaging right now 70 patients per day between the 2 clinics, and that seems to be expanding rather rapidly. We also finally started having DME available at all of our clinics, and we see about 7,000 patients a year at all of our clinics for that. We've also upgraded our MRI software so we can do more scans per day and enhanced our scheduling. So we're getting more of those done as well for much less expense than at the hospitals. Everyone's been impacted by COVID-19. Our big thrust in the beginning was to give the health of our staff, because as you know, you can be open, but if you have no staff, nothing happens. So we've been very strict and thorough with policies about COVID. We have a dedicated person at the Department of Health that we turn to if we have any questions whatsoever. And we have a task force that met basically daily in the beginning of this to try to sort this out and see what the best direction might be. We have had much more strict and refined screening procedures than any of the hospitals for our patients at the ambulatory surgery center. And now we're starting to do rapid testing for urgent and emergent cases at our surgery center, which you don't want people, hanging around with fractures for too long if you can get a rapid test done. Only in the last month or so have the hospitals been forced to cancel elective cases. And that's pushed some patients to the ambulatory surgery center that might not have chosen to do that before. But we certainly welcome their business. We are the only independent orthopedic group in Spokane, except for some very smaller 1- and 2-person groups. Providence has 2 big hospitals. Multicare has 2 fairly large hospitals, and they've also purchased all the primary care clinics and most of the urgent care centers in town. So that's an issue we have to deal with. They collectively employ about 16 orthopedists, and they continue to recruit orthopedists around us. This has been addressed with them before. They continue to do it. We have noticed that their patients, even if they've previously been our patients, are referred internally within their system. And despite all these things, we still try to maintain a spirit of co-opetition with them. We still maintain leadership positions in their orthopedic programs, and we'd like to work with them somehow, but how that's going to work is unclear at this point. So the things that we find challenging, as everyone does, is declining Medicare and other reimbursement is certainly problematic. Insurance companies get sneakier all the time with changing insurance plans and excluding providers, bundled payment plans, et cetera, most of which are beyond my ability to understand. That's why we have a great administrator people that do that. So the future is unknown, but we're doing the best we can. And I think collaborating with all and some of you and sharing ideas could certainly be helpful for all of us. So that's that.
Great perspective. Thank you, John. And thanks for taking the lead off. One question, then we'll head to Dr. Pottinger. And you gave several great segues for his presentation and his thoughts. In terms of these larger chains and the co-opetition, that's a great word. How formal are the negotiations with that? And why would there be an interest of these large healthcare cooperatives to exclude you? Are you, quote, expensive? Do you not fit the norm? Are you not compliant with policies? What's the incentive for larger chains to kind of try to squeeze a well-established, very well-recognized group like yours out of the way?
Well, I think you'd have to ask them. I think it comes down to that basically their profitability is better with their employed physicians than with us. We have our performance metrics and whatnot, and our infection rates, all those other things, and we compare very, very favorably to the employed physician model we have in every respect. And they love to combine our physicians' data with their physicians' data at a sort of an aggregate database that makes them look better. So why they don't want to play with us, I think, has all to do with fiscal responsibilities there. So
I think we should explore more. Full disclosure, I work obviously for one of those larger healthcare entities that John was just referring to. And again, I'm sitting in those internal data committees, and I think this should be explored in greater depth, because data validity is always a great subject. And again, I absolutely always would like to have the best practitioners in the healthcare system I work with. And I'm looking at you as an extremely experienced traumatologist and sports medicine doctor. I'd have no problems running over to Spokane to you to have my long overdue knee osteotomies done, for instance.
come on over.
So without much further ado,